Here it is. So I'm talking to you about data. So I wasn't quite sure how to pitch this really, because there are some people here that know loads about data, not just medical data, and some I suspect don't know. So forgive me if it's too detailed or too simple, but here we go. So what I'm going to talk about is, first of all, different kinds of data. So those would be like the type of tumors, for instance, and then the demographics, so the type of patients, and then I'll talk a little bit about quality of life and symptoms and PROMs and PREMs. I'll talk a little bit about how we collect the data and how you can collect the data, and a little bit about how to publish the data. So the different origins of data collection. So this is really important because what you see in presentations of data is very frequently in the first column here. So it's from hospitals or net centres. So when you look at data that's presented, for instance, survival after a drug, those patients are virtually all from net centres. And that doesn't include everyone that have net, because a lot of patients can't get to net centres or don't want to come to net centres. So there's a tail of the population that are left out of that data. So it's important data, but it doesn't include everyone. From that data, you can get detailed information from the clinical notes. So it's detailed and useful data. The second column there is from population databases. So that's what I deal with mainly. So what these are databases which exist in each country, and they tend to log all the pathology. So nearly all of our patients that have a cancer have a biopsy or a specimen or some cells. And if they have some cells, they'll be logged on a pathology database. And in most countries in Europe, there is a registry of that pathology. And so there are a lot of countries in Europe that have virtually 100% of the patients. And those countries include UK, includes Norway, Sweden, Netherlands, Germany. I'm not sure about France and Spain, Italy, to be honest, because I haven't seen any papers on those databases, but these do exist. And the funny thing is that these population databases are often completely divorced from the net centres. So the clinicians working in the net centres often don't have access to the population databases and vice versa, which is a weird thing, isn't it? Because you would have thought they would be talking to each other. But I know in the Netherlands, they do talk to each other, and I think in Sweden and Norway, but a lot of countries, there's no crosstalk. And the third way you can get data is obviously from groups like yours with patient organisations and support groups. So they're really important because people are prepared to volunteer their time and put their data on. We have to remember this is a selected population, so not everyone will log on to a patient support group, and not everyone will want to, and some people won't be able to. So we need to remember that. So how do we collect data? Well, you can collect it from patients prospectively on a laptop or a phone. You can do it in a paper-based format. You can do it through social media. So all are possible. Obviously, some elderly patients may not want to do it on social media or from a phone. There's several papers published about the difference between these data. There are minor differences between this data, but by and large, I think most people accept now that paper-based entries are pretty much similar to what you put into a laptop. So there have been studies on that. If you collect data from hospital records, you'll need ethics for that, so that's slightly more complicated. And as I say at the bottom, from databases or registries, they're filled in by specialist coders and admin people who are generally not medical trained, but they're pretty accurate, most of them. So as an example of a center-based data, so this is just one of many studies. So this is from a single lung center at Guy's Hospital who happened to do a lot of surgery on NENs. So it's a single center data. All the pathology has been reviewed by a single pathologist, so we know that all the pathology is exactly correct. We know the site, stage, age, sex, and everything. We know they're all accurate. And the survival is accurate because we know who's died and who hasn't. So it's a selected sample. So it's not the same as the population. If you do this in a population database, you'll get a different answer because this is a single center. So whenever you're looking at data, you have to know, is it a single center, is it multiple centers, or is it a population database? Because they give different answers. So this is just the data from this center. It's not very exciting. It shows you survival. For those that are not familiar with survival curves, basically on the left-hand side of the graph is survival up to 100%. So where it says 1.00, you can think about that as 100%, and 0 is the baseline, and time there is in months. And those are the people that have died over many years, and as you can see, not many of them actually have died during that time. And as you know, the survival following resection of lung nets is pretty good. At 5-year survival, 95%. And it has the advantage that you can look at different operations as an example, and there's lots of data in this series, but as an example, you could look at 4 different kinds of operations and see if those curves are different. So that's a really useful thing to do because you could make a prediction about whether which operation is actually going to be the most useful. And you can do statistical tests on those to find out whether you think a particular operation is better than any other. So it's just an example. The actual data is not that important. It's an example of a single center series where you've got really accurate data, you know exactly what's happening, but you have to remember it's not necessarily going to be the same in another surgical center. So that's what we have to remember. So moving on to population data. So this is like in UK, it's called NCRAS, National Cancer Registration Analysis Service. In the States, it's called the SEER data, Survival End Results Database. And there's a German registry, there's a Norwegian registry, Swedish registry, etc. So the tumours are only looked at once, and then they're put into the database. So that you hope the pathology is correct, but the pathology has not been reviewed again for the trial. So you have to accept what is put in at the start. The stage, because what the pathologist gets is a tiny sample of tumour, like this size, 2 millimeters. The stage of a tumour is how far it's spread. So as you can imagine, the poor pathologist only has this much tissue, and he doesn't really know how much of the patient has been affected by this tumour. So the stage in these databases is not that accurate. But the grade of the tumour, which is determining how many mitoses and cells there are, is really accurate, because that's what the pathologist has to look at. And the big advantage, as I say, is all tumours are included. So every single tumour, well, when I say every single tumour that has a biopsy is included. Now, as you know, there are a few nets that won't have a biopsy. There's not many, but there are a few, and they'll not be in this. So occasionally there's elderly patients that present with flushing. They have a raised 5-HIAA, they have tumours in the liver, and we say we want to do a biopsy, and they say no, thank you. And those patients are not included. So you have to remember that. So I'm sorry about you've seen this slide before. This is Ben White's data. So this is an example of a population database. So pretty much 100% of the tumours are included. And we've talked about the increase here over the years. and the different types of tumours increasing over the years, it looks to us like the lung tumours may be reducing. That may be partly related to the reduction in incidence of NECs that we know about from the Norwegian data as well. But the interesting thing about the data that we have with INCA is you can tell where people live. So you obviously don't have their address. You're not allowed to have their address, but you have within an area of about 2,000 patients, you know how many neuroendocrine tumours there are in each small area of England. And so you can map where the patients are. So we thought it might be interesting to map the centres of excellence in England, which you can see there on the left. And then we thought we might map how long it takes for them to get to a centre of excellence. So we know where they live, and we know where the centre of excellence is, so we computed what's called the driving time. There's a thing called the driving time that you can look up online, and you can find how long it takes to get from somewhere to somewhere else. And so we looked at the driving time, and so as you can see on the right, the areas in red are people that live in a place where it takes a long time to get to a centre of excellence. So there are quite a lot of those, and as you can see, the centre of excellence is sort of in a big swathe up the centre of the country. So on the peripheries in the east and west, it takes a long time to get there. So we thought, well, we'll look at survival. And the odd thing is that if you're further away from a centre of excellence, you don't survive as long, which is a weird thing, isn't it? But I guess you might expect it, but that's what happens. So I think that's the first time that's ever been done. And also, when you plot the incidence in England, there are certain hotspots. As you can see, the dark purple are the hotspots. We've actually been unable to find why these hotspots are there. As you can see, there's one down in the southwest there in North Somerset. So these are corrected for population density. So if we just put all the NET patients, most people would be in London because that's where most people live. So these are corrected for population density. So they're what's called anomalies. So they're anomalies in terms of incidence. So what we did was we looked at radiation. So there are certain areas of the country where there's high radiation, and there didn't seem to be any correlation. We looked at power lines, and we looked at microparticle pollution data. So as far as we can tell, there is no correlation with any of those relating to where people live with NET. So that paper has been written and is being considered for publication. The other thing that the guys have been doing is looking at emergency presentation. So in the data that we've got, we know who presented as an emergency just prior to their diagnosis and who presented as electively and was seen in clinic before. So we thought one of the problems, certainly in UK, is delayed presentation. So we're using emergency presentation as a sort of surrogate for delayed presentation because they're presenting as an emergency, they've not been seen before, and we thought it'd be interesting to plot their survival, and lo and behold, those people with a late presentation do much worse. So you can see that the survival is really bad compared to those that present electively and present at an early stage. So I guess that might not be surprising, but again, I don't think it's been described before. I'll mention the biobank. So I was talking to Thor about this yesterday. So this is a separate database. So in the 1990s, Tony Blair was Prime Minister of England. He agreed to setting up the UK biobank, which they asked for volunteers, and they got 500,000 people in UK to give blood and be weighed and have the girth and blood pressure and lots of other things measured. And it's now been 30 years since they put them in. So we have 30 years of follow-up, and all those patients have had whole exome sequencing of their DNA. So there's 500,000 patients have had whole exome sequencing, and they all have follow-up and clinical data. And we've looked at that. We can't find a single mutation in the DNA that predisposes you to NET currently. They all have follow-up data. The NETs, and particularly pancreatic NETs, are strongly related to obesity and type 2 diabetes. That's one of the other things we've found, but we're analysing that at the moment. So that's another biobank. I'm going to talk a little bit about PROMs. So there's a lot of heated debate went on about PROMs earlier, and it's a real problem. This measuring quality of life is really difficult. In my view, they're best assessed by validated questionnaires. The questionnaires tend to be very long, and there are several reasons for that. And as you know, the GINET, I hold my hands up and say I'm responsible for the GINET 21, but it took about 10 years to do the data validation of that, so it was not an inconsiderable task. But that's what we came up with, and you know, maybe I think it's about time someone came up with something better, but at the moment that's what most people are using. So should we talked about this before, should we have just symptoms in it, or should we have symptoms plus anxiety and depression? I mean, in my view, we should probably have both. There's a thing called computer adaptive testing, which I think is going to be really important in the future, and all that means is that if you answer a first question in a computer adaptive testing saying you can't walk, then you don't go on to lots of questions about how far you can walk. You know, it stops there. So, and there's lots of adaptations to the questionnaire as you go through it, and I think that's going to be really important. There's a thing called PREMS, which is assessing your experience of care. And there is one that we developed with eNets that is being used for centres of excellence at the moment. Again, they tend to be very long, and I can understand why it's really boring for people to fill them in. So this is just the GINET 21, which our group developed years ago, but as I say, it was a labour of love, really. So the problems with quality of life data are, number one, if you have missing data in a trial, so if someone doesn't fill in a questionnaire at, say, 2 months, you've got a figure that's missing, and there's lots of debate about whether you average that value or whether you miss it out or whether you try and put something else in. And missing data is a real nightmare. There's question fatigue, which we've discussed. People get fed up with questionnaires, and it's been shown that by the time you get to the 51st question, you're not answering it as well as you were on the first question. So, you know, that's not that surprising, is it? The paper or online thing or phone, I think, has been sorted out. They do seem to be equivalent. If the patient can't fill in the data, there's a question about whether relatives or friends should fill it in for them, and that's called surrogate data entry, and there are problems with that. I won't go into those, but you don't always get the same answer for whatever reason. There is longitudinal data, so when you're trying to measure quality of life over time, it's affected. If you take a mean of that, it's affected by people dropping out. The people that are most ill tend to drop out, and therefore you have no data at that time point, and that affects the mean of that data. And I'll show you why that happens in a minute. So this is an example of a sort of rubbish output from a quality of life study. So we published this as a bleak study. This was a study of everolimus. So what we were doing is we were measuring quality of life every month for 6 months after going on everolimus, and we were trying to see if the quality of life got better or got worse. And what you can see there, I don't know if you've seen box whisker plots. This is a box whisker plot, but the very long lines in each quality of life time point just mean that there's huge variation in the data. So none of this is significant. So you can just see it's just a mishmash of means of quality of life over the 6 months. It doesn't really mean anything apart from, and at time point 3, these patients were, seemed to be having a bad day. And there may be hundreds of things that gave them a bad day and reduced their quality of life. So that wasn't very helpful, really. I mean, more realistic is in the NETA-1 study, as you can see, what this is a time to deterioration. So what they're measuring is the time to a reduction in quality of life. So it looks like a survival curve, but actually it's a sort of survival curve of quality of life data, which is a difficult concept to get your head around. But you can see there is a big difference in quality of life if you have lutetium or if you don't. So that's what it's saying, and that's useful, I think. Who's going to analyse the data? Well, I expect I noticed there's some people, economists and stuff here, so I expect there's loads of people here that are used to looking at data in Excel and doing confidence intervals, and you can do correlation stats in Excel. If you really want to use data or R or even Python programming, you need to be an expert, and there probably are experts in the audience, but you probably need to get a statistician to do that for you. Having said that, the future is definitely artificial intelligence for this, because in the future you're probably going to be able to collect a data set and plug it in to an artificial intelligence program, and it will sort it all out for you and give you an outcome. So that's probably what's going to happen. And we've got a couple of people in our group who are really into this, and this is an outcome. So this is our patients with correlation of survival with various things. And this is a graph like I've not seen before. I don't know how many people are used to, this is called a Shapley plot. And this is new, and what you're looking at is if the red bars are to the right, that's of high significance. So you can see that stage, morphology, and age have a high significance with survival in this plot. So these are really difficult things to understand, I think. There are probably people in the audience that understand Shapley plots, but they're quite new and quite difficult to understand, but you'll be seeing a lot more of these. So they're essentially correlations of certain factors with survival. And this is just another, this is actually going to ESMO next week. This is an abstract where Mohammed has looked at thousands of patients and looked at different groupings. So the artificial intelligence sorts out different groups of patients based on hundreds of characteristics, and then it looks at survival. And as you can see, there are certain ways of analysing the data that give you a survival difference, and then on the bottom right there, you can actually develop a decision tree based on all those factors. So we'll be seeing a lot more of this. It's a bit hard to understand, but this is definitely the future. I'd just like to say in a few minutes, what about publications? So I've heard people saying that they want to publish. Do you really want to publish? I think you need to decide that before you start. It does give you worldwide exposure, but it's actually a pain in the arse, really. And for those of us who've sat there at weekends writing papers and rewriting them and answering questions, it's a real slog. So you really have to want to do it. If you really, it's easy to say I'd like to write a paper, but it's a real slog, to be honest. So which journals impact, is an impact factor important? You're probably not going to get your paper on quality of life in patients published in the Lancet or the New England Journal of Medicine. It's not going to happen. So you need to aim to different journals. And I would strongly recommend getting professional writers to finish the product. And a lot of the pharma companies have these people, but that's what they do as a living. And if you do that as a living, you're good at it. And so they will write your paper for you if you can afford to pay them, or the company will afford to pay them. So which journals are we looking at? So unless you're an international researcher, forget the ones on the left. Then it's not going to happen. So you'd be doing really well if you get a paper into the medium ones. So that's endocrine-related cancer, Journal of Neuroendocrinology, Neuroendocrinology, or Cancer's MDPMI. We're more likely to be aiming at the ones on the right. So Journal of Cancer Care, Frontiers in Oncology, Current Oncology, those sort of journals which have an impact factor of 3 or 4, that sort of level. So that's what you should be aiming for, in my view, unless you've got absolutely fantastic revolutionary data. There's a thing about processing charges. As you know, the journal will often say, we want $2,000 for processing charge. And you say, well, actually, I haven't got $2,000, so what am I going to do? So there are some universities, if you belong to some universities, they will waive that if you're part of a university. If you're applying for a grant, you should include the cost of the processing charge in the grant. And if you get a refusal, you should try again. You should challenge the journals, because sometimes you can say you're a charity, you don't have any money, and they will actually waive the fees or reduce the fees. So it's worth asking them. I think I'll gloss over this. This is just something that I put in. And that's really the end. So good luck.
So I just have a question, and this may be for you, and that was such a great presentation. I learned so much. Thank you so much. I feel like I've picked up a lot of that along the way, but having it arranged in such an excellent way was very valuable to me. And I may be confusing the terminology because I'm new at this, but the processing charge versus, like, when we got published, we realized that it wasn't necessarily an open access article, and obviously we're a patient advocacy organization. We want everybody to read it that possibly can. And patients could get free access individually, but they had to go through and register and go through some hurdles. So I was curious if you or anybody else who has experience publishing, how you handle that, and if you make sure that you budget for that, or can you ask the journal if they'll waive the open access fee, and how, like, any advice regarding those matters?
Yeah, so most journals are moving to open access. So there are fewer and fewer journals that don't have open access. If you can get your paper published without open access, that's half the battle. But then, as you say, they'll charge you for open access. There's no harm in asking to waive the charge. It doesn't cost anything to ask them, but it's a bit of a long shot. I don't know if anyone else has experience.
I have a question as well. Big surprise. I loved your presentation. Thank you so much. I don't know whether this is a question for you or not, but we're trying to set up a patient registry, and we're having a heck of a time. And we've had quotes that are millions of dollars, literally, and it just seems really out of line. Do you have any thoughts of resources we could look for? I mean, our data is Stats Canada, which I've worked with as a planner, but like Net Cancer isn't like taken out of that, so that's part of our ongoing data problem. But really, it's just a patient registry that we're looking for. And we've been told we really need a champion at a hospital and a doctor who will support it, and they're just not amenable to that. So I don't know whether you have any leads of places we could look for sort of a 101 on basic patient registry.
I don't know where you'd go to get money. I mean, I would talk to Julia Hallett. You presumably know Julia Hallett, don't you?
But I'm not really looking for money. I'm just, looking for ideas to set up like a real grassroots kind of, registries for dummies.
Yeah, I mean, these are happening all over the place. I have to say that I'm not a big fan of creating nationwide registries. They're starting to do one in UK at the moment, and there've been 11 iterations of the UK database, which Kathy and I have been involved in many of them, and it hasn't happened. And it seems crazy to me that we're going to spend millions of pounds creating a registry when the data is already collected by NCRAS at the government's expense, and it will be in Canada as well. I mean, Julia Hallett knows all about this. I mean, she's an epidemiologist of international repute in Canada. She will tell you what the score is. And I'd contact her, really, honestly.
Thank you, John, for that lovely presentation. I have one question and one comment. My question about this database, how do you keep it? Is it de-identified, anonymized, or is it within the hospital database where it is still identifiable and not anonymized?
It's anonymous.
Anonymous.
But when I have to apply through ethics with a very long application form to get the data, which I have done, it took a year, and they send you the data, anonymized data, so I can't relate my data to hospital medical records at the moment. But I mean, my argument is ultimately, everyone should do that because the data is collected. If we create another database, we're entering 60,000 patients by hand into a new database when it's already been collected.